And I did start as an epidemic social worker with the HIV and AIDS epidemic. And now I'm here for this one. So I decided to go a bit of a different route for people tonight. I'm a person who is very much a believer in painting a picture and helping people to really understand the depth of what they've been charged with to do in their life's work. So that is why I'm going to take this little bit of a different approach this evening. We do have some slides up just in general about the work that SafePoint does. You are all more than welcome to keep these slides, use these slides. I'm sure Dennis and Pranav will include these for you to take with you when you guys leave the presentation tonight. But for me, I am going to talk to all of you about moments as soon-to-be medical professionals. When I was asked to speak today, knowing that I would be speaking to future medical professionals, I thought about what slides or data would be needed to show you on the importance of how a person should treat and care for somebody who is struggling with addiction. What charts would have the desired impact I wanted? I decided, however, that you already have endless data which exists and could be researched at any time to show you the importance of harm reduction and the work my tiny but mighty team of 8 plays every week in a city that is overrun with an epidemic. Along with my own moments in a 20-year career as an epidemic experience social worker, I chose to impart a different message into your day, today's studies, your endless hours of research, which can sometimes distance medical professionals from remembering that at the end of your education, you will take an oath to treat and to show compassion to human beings, regardless of who they are or what brought them to you. An oath that does not have a place for judgment or assumptions, only that you do all you can to protect and attempt to preserve the life that's in your care at that moment. You will surely encounter people in your career who may have life-threatening abscesses, endocarditis, collapsed veins, hepatitis C, all things that can come from addiction. In that moment, what will you do? Will you label them with an unfortunate title, say their actions caused the illness they suffer from, provide them with little compassion, and dismiss them too quickly from your care because you think it's a lost cause? Or will you choose in that moment to see them as a person who is ill, who could lose their life if not treated appropriately, a person scared and forgotten by society, one who is in immense physical and emotional pain, who is trusting that you will make them well, show them kindness in their vulnerability, and maybe even help shift the hopeless mindset that they hold, show them that they do matter. Remembering always that how you treat those who suffer can affect how one person will see an entire profession. In that moment with you, you could very well change their ability to trust medical professionals they will most surely need in the future. Just like the female that I met yesterday, as I checked on those in a homeless camp, she's one of our participants at SafePoint. She emerged from her tent, the side of her face swollen to twice its size up to her temple from a possible abscessed tooth. I told her she needed to get to a doctor quickly, and she began to cry and instantly reached out to give me a hug. I've known her for a long time, and this is some of the worst condition that I've ever seen her in. She would rather have a hug from me and a meager wound care set that we provide at SafePoint versus going to the ER. When I asked her why, she said she didn't want to go. She said, I will sit forever. They'll forget I'm there. Then they'll come back. They'll cut me open and give me a prescription I can't even fill. Stories like these happen more frequently than anyone would want to believe or would like to admit. This is most surely not to say that all medical professionals are dismissive to those addicted, but only to say that changes of mindset need to happen, and soon. Maybe I can start that shift for you today. I also chose not to show my face to any of you, because someone who becomes addicted could be anyone, yourselves included. There is no typical face of addiction, period. only what society has placed in your mind, and that is the face of stigma that you must fight against in your career. To put it simply, that face is your aunt, someone's brother, the best friend you've known for years, a favorite teacher, or a coach. Medical professionals are highly respected. People will listen to you when you speak. So you must use your platform for the good of individuals who don't have enough people fighting for them. My face of addiction is a 28-year respected RN, my mother. She was judged and dismissed by so many. They chose stigma rather than knowing Charlotte, the nurse they had worked alongside for decades. They defined her by addiction, but that addiction did not make her less of an RN. It didn't affect the passion she held for her profession or her patients. And I think that that is extremely important for you to remember. A person's addiction isn't what defines them. Society has done that to them. Society has labeled them as weak or somehow less than deserving. What I hope all of you will understand is in that moment, everything can change for someone in one moment, both for better and for worse. In a moment, someone could be in a car accident at 17, which may give them a life of pain that they are forced to manage. In a moment, a night out with friends could turn into what might seem a harmless experimentation with a substance that had never even been entertained by that individual. In a moment, somebody walking home could lead to a brutal assault, which results in PTSD for that victim. In a moment, a child could be sexually abused by a family member, a cycle of abuse that could continue for years. We are all one moment away from possible addiction. I assure you, none of these moments were wanted, nor would the person think a moment like these would lead them to addiction. A way to somehow manage their pain or trauma is how they saw it. It will not be your job in that moment to assume anything about the person in front of you, but only to treat them as you would want somebody to treat you. Use your moments to understand what I feel is a very important principle as a medical professional, to care for yourself so that you may care well for others. As medical professionals, self-care is not practiced enough. You are not told what the pressure of being able to save a life can hold for you. You must do what is needed for yourself so you can remain objective and compassionate throughout your career. If that means a weekly massage or regular counseling to process all you do and see, then you must do that. It should be a normal part of your daily life and come with the territory and the job that you've committed yourself to. I can tell you that without things like that in my own life, 20 years as a frontline social worker would not have been possible for me. I would have burned out a long time ago. You are just as important as those that you treat. So don't think your battery doesn't require care and charging. Unfortunately, this epidemic will touch every new medical professional's life. Your practice or your hospital will be saturated with overdoses, ER visits, and the fallout from opiates. It is easy, of course, to become numb when you see the same cases and faces day in and day out. To forget that it's not a waste of time to help the same person 3 times in 1 week, but rather it should be you knowing that you've been given the privilege of seeing someone in need that frequently. And remembering each moment you spend with them matters and could reroute their journey. When you look at them, I would ask that you imagine yourself in front of you, sick, scared, in overwhelming pain, and utterly alone. What would you hope for in that moment? And then I ask you to do just that. SafePoint's Blue Door is always open to any of you at any time. We have a living document for you to come and witness, and Pranav and Dennis can of course be testament to that. Take time to come and see and talk to the people that we see and we talk to every week, that we have built trust with, in the judgment-free zone we provide and create for them. If you come to that space that we've created for them, they will know that you're not there to hurt them, only to help and to learn, and to hopefully one day help them. We are always happy to have you. And remember above anything else tonight that moments have so much power. So please make the most of the ones that you are given in your career. I'm truly, truly thankful that Pranav asked me to speak to all of you today, and I really hope that all of you become amazing moment makers. So thank you guys so much.
Thank you. Thank you so much, Elizabeth. We're going to move into a question and answer period. So the chat should be enabled. If anybody wants to ask a question for Elizabeth in the chat, you can take a moment for you all to type that out. Or if you'd like to raise your hand, I can unmute you and you can ask it on your microphone. I'll just give a few moments for people to maybe form a question.
And even if you think of anything later on, Pranav and Dennis can certainly supply my email to all of you. So if you want to ask questions later on, or if you want to schedule a visit and come out and see us at SafePoint, we would be so happy to have you. We have students that come all the time, some of whom have even chosen their career paths because of their time with us. So we really welcome you to be there. This, unfortunately, is an epidemic that's going to be around for quite some time. So it's going to be important that more people are exposed to what we do. Can I explain the intersection with the medical side of treatment as a social worker? I absolutely can. Before I came to SafePoint, I actually worked at CompDrug, which is a treatment center here in Columbus. They offer several different kinds of medically assisted treatment like methadone, Suboxone, Vivitrol, but we also offered intensive outpatient services and services to individuals who didn't necessarily want medically assisted treatment, but just wanted the counseling and the groups. I think with the medical side of treatment, it's easy for medical professionals to think that they, of course, know best. And I'm not saying that they don't, but I think what can sometimes get forgotten is that we don't listen fully to the person that's in front of us about what they need and what they want at that time. So SafePoint and harm reduction is very much a journey about meeting people where they are in that moment. And we walk alongside of them. We try very, very hard to not walk in front of them or behind them. We want to be right next to them on their journey. And sometimes, in order for them to get to a place of understanding about the medical side of treatment, a whole bunch of things have to be done first. A whole bunch of barriers have to be removed before we can get a person to that place. So if you think about it like this, somebody who is struggling with addiction, who might be housing insecure, so they're homeless, they only have what they can carry on their back. They are typically a moving target to individuals who would want to rob from them or take advantage of them. They might not have a phone, they might not have an ID, any way of identifying themselves. We have to take care of those barriers that are in their way of treatment first, which obviously as a social worker, I don't really agree that, somebody needing an ID is absolutely necessary for them to get into treatment. More places are starting to be open to that concept of not needing a valid ID. But still, it's a barrier that many of our folks encounter. And if you can't meet a person's basic needs first, their housing, food in their belly, warm clothing, they aren't going to be able to see far enough ahead of them that, oh my goodness, I have to get into treatment right now. I need to start working on my recovery when they can't even feed or house themselves. So that's what harm reduction is all about. It's about meeting that individual where they are, working with them slowly and patiently to build trust, not only of our staff at SafePoint, but just trust that there are individuals outside of the 7 of us who do want to help them, to try to help break down the barriers that they've encountered from people who unfortunately have treated them poorly in positions where people were not supposed to do that. So we have to work on all those things first before we can really get to that intersection of medical treatment and, being a social worker. I'm an advocate. So a social worker is just this living, breathing advocate for a person to work with them. So if I have to talk to a facility on somebody else's behalf, I'm going to do that. If I have to, work longer on a given day to make sure that a bed is ready for somebody, I'm going to do that as a social worker. So they can hopefully have a path that's a little bit easier to navigate for them. But I can tell you, it doesn't always work. I have been right alongside with my people in front of other providers who needed and were charged with helping them. I've been right next to the person, and they have gotten no farther sometimes with me being there than if I wasn't there with them, because there is so much stigma right now for this population. So I hope that that answered your question. You're welcome.
Does anybody else have any questions they would like to ask Elizabeth? Okay, as Elizabeth said, if anyone has any questions after this, feel free. I can provide you with Elizabeth's email, or I can ask her for you, whatever's easiest. Elizabeth has a great amount of experience, so thank you so much. We will move on to our next speaker, Dr. Kauffman.
Great, thank you. I will turn my camera on. So hello. I am an emergency medicine, I guess I'm the medical side here tonight. I am an emergency medicine physician. I'm also an internal medicine physician. I'm dually trained. I practice both at Ohio State. I've been there since 2012. I've, unfortunately been a physician longer than that. So I've been doing this a while. Evan Rooney actually asked me, told me about this event. I wasn't familiar with this organization. So thanks, of course, for having me. I do want to make this informal too. It looks like it's a pretty small group. So please raise your hand, or if you've got questions in the chat, that's fine. I don't mind. That was a very eloquent first discussion. I appreciate that. Wish we had somebody that passionate. There was one of our social workers in our emergency department. I think you would be a fantastic advocate for many of our patients. And I unfortunately did work in the emergency department today. And I am not new to this epidemic at all. And the last 48 hours have been pretty bad. So there is a rip-roaring uptick, since fentanyl, which is not new. Fentanyl was really introduced into the market around 2013. I'm sure most of you are probably familiar with the sort of complex origin of this current epidemic. But it particularly now seems to be heading in very much the wrong direction, even before coronavirus, came to town. So we are hitting a horrible intersection of mental health and substance use right now, and it's putting people in a really unfortunate position. But anyhow, I kind of wanted to tell you guys a little bit more about what is happening that's positive on the medical side. I don't know if some of you are going into medicine or your undergraduate students. I don't really know what your interests are, but if you do, whatever field you land in, I hope to sort of spark an interest in addiction medicine and compassionate care for people with addiction. Because when I was a medical student, we did not really have training surrounding substance use disorders. There really was not enough training. We were taught in a very limited fashion how to treat pain, but we were not treated or taught about how to interact with folks with underlying substance use disorder. We were taught how to treat withdrawal symptoms, not appropriately for opioid use disorder, but we sort of missed that whole curriculum, unfortunately, and then we caught ourselves up with the opioid epidemic. Going back to what's happening at Ohio State, I am the sort of lead physician for our initiatives in the emergency department. Ohio State has been pretty progressive in this area. We have been distributing naloxone kits in the emergency department since 2015. That was under the tutelage of Dr. Mike Dick, who is the medical director there and still is the medical director there. Since about 2017, with various grant awards, we were championed to basically change how we were interacting with folks, and particularly with opioid use disorder, because that's, you know, right now where all the funds typically lie, and so where a lot of this work, you know, typically gets done. But keeping in mind how we address patients with substance use disorders is really across the board. We should be doing the same things for all patients, because we're not just seeing opioids. We see stimulants, we see alcohol, we see benzos, we see, unfortunately, the predominant are polysubstance use. But basically since 2017 and really wrapping to 2018, we had a large award from the Ohio Department of Health. And we essentially were able to adopt a very comprehensive approach to how we interact with patients presenting with opioid use disorder in the emergency department. So currently, you know, if anybody's familiar with the emergency department, we have certain crisis situations. So we have trauma activations, we have stroke activations, we have STEMI alerts, or those like massive heart attack alerts. But we do not have anything to announce when a patient presents as an overdose. You know, for many years it was, well, they're going to leave, you know, like there's nothing I can do for them. They're going to rip their IVs out. Like I can't get to them soon enough. And so there has been somewhat of this rallying cry around patients presenting, you know, not just overdose, patients, you know, in crisis, you know, with a medical complication, because it can be anywhere from a skin and soft tissue abscess to, you know, full-blown something called endocarditis, which is basically a bacterial infection that comes from a heart valve infection, and it'll seed throughout the body. And it can lead to, unfortunately, numerous complications, including stroke and, unfortunately, death for many. So the gamut is quite wide for these folks. But we have tried to instill a program that will address patients on all spectrum. You know, maybe at the early stages, you know, maybe they had a prescription for an opioid for an ankle fracture, but they've got a family history of addiction. There was some childhood trauma. They don't have a great sense of connectedness with their family. They're detached from school. They're sort of in that ripe sort of priming to develop a substance use disorder, but they haven't quite gone there yet. They're maybe thinking about buying some, you know, Percocets on the street. They've done it a couple times, but they're not quite there yet. So we're hoping in the emergency department to capture those folks maybe early on the spectrum, to those folks with a disorder, to those folks like, unfortunately, at the very end of the spectrum with multiple medical complications. So when somebody comes to the emergency department at Ohio State, they're screened, you know, even if they're not presenting with a complaint related to opioid use disorder, they're screened for whether they're buying any illicit like opioids on the street in the last month. And if they are, because the nurses will ask patients coming in a lot of questions like about coronavirus, about domestic violence, about, you know, homelessness, you know, are they suicidal? Because we are the safety net for society. We're the only joint in town open 24/7, right? But so we want to find out if they're using anything illicitly, and then if they think it's a problem, and if they think it's a problem, do they want help? So we're somewhat pre-screening for folks, you know, if they're having on that sort of stages of change, if they're maybe in a contemplation phase, just right off the bat. And if they are, we try to get our social workers involved. We have ED social workers that are invested in substance use care. We're actually looking to hire a specific social worker who will do a lot of the work that you heard from the previous speaker, but maybe in a little more condensed fashion. So basically trying to screen the person sort of where they are in that spectrum, you know, kind of doing what we call a brief intervention, and then potentially referring them to the appropriate treatment setting, depending on where they are. We have peer support in the emergency department. We've had that since about 2019. This grant that we had was able to support this particular feature. So these are folks with shared experience in recovery. They are there to engage folks at bedside, determine their needs. They can assist with care coordination, but they also, most important thing is that they can follow folks in the community beyond their discharge, which is an invaluable asset. It also helps quite a bit. And when we first started the program, and I think the previous speaker alluded to this, I think my biggest challenge that I, fight along with my comrades who do this work in the hospital setting, the medical director of Talbot Hall, which is our inpatient withdrawal management facility. I work with an internist who runs our medication assisted treatment consult service. And so she basically sees all the patients admitted to the hospital, and she and her team members get these folks started on Suboxone or buprenorphine. And then we have an addiction medicine team as well. We all work together. But I lost my train of thought. I'm sorry. I work today, so my brain's a little woo. But in terms of peer support, we get the folks to engage, bedside to see what their readiness for change is. We will give them a Narcan kit. We've been doing fentanyl test strips since 2019 because pretty much all substances that we're seeing on the street are somehow, cross-contaminated, admix. I don't know what the deal is, but it seems like fentanyl is just about in everything. If somebody wants to go to treatment, depending on if they want an inpatient level of care, which sort of limits our trajectory, and depending on the time of the day, we can make that happen on most circumstances. If they're opioid use disorder and they're in withdrawal and they want to be started on Suboxone, we can do that in the emergency department. We have about 65 physicians and nurse practitioners and physician assistants who have taken this specialty training. So I don't know if you all are aware, but to prescribe buprenorphine, you actually, as a prescriber, you have to take an additional training from the DEA. So, for most, it's about an 8-hour course. It's free. The state of Ohio offered a stipend to take this course, a couple of years ago. So we were able to get a lot of folks trained, but you cannot write a prescription for buprenorphine. Trade names would be Suboxone or Subutex without this additional training, despite being, a licensed physician, nurse practitioner, physician assistant, and already having a DEA number, you have to have additional training. So there's a lot of legislation actually happening right now to get that waiver removed, which would definitely, I think, reduce barriers to care, because that's what we're aiming for. I think a lot of the problems, like the second problem in our society, along with stigma being like the huge, probably the top leading concept and barrier to care, is just access to care. So when people are ready to go, it's often a narrow window, and if they're ready, you got to mobilize your resources. And even when they're in the emergency department in a monitored setting, if you miss that fine line between they've just used and then they're starting to go in withdrawal, and you haven't necessarily started them on meds quick enough, or you haven't mobilized your social worker and your resources, quick enough, it's like they're gone and you've lost that opportunity. And the problem is, particularly with opioids, especially mixed with all the stimulants, cocaine, meth, it's most prominently cocaine here, and at least on the east side. There is such great lethality with it. Folks leaving the department after an overdose without any services, without being licked in treatment, you potentially can be as high as a 50%, risk of death in like the next month. That's huge. I mean, we don't see that type of, rates of mortality with most of the patients we're discharging from the department who are already admitted with chronic medical diseases. This is a chronic medical condition, and it's required a lot of education of our providers. And I'm talking all providers, not just like physicians, nurses, the patient care, assistants, the registration clerks, the people delivering the food service, like anyone who interacts with a patient with a substance use disorder, there is stigma there. And it's the amount of education we've had to do is just, it's like infinite. You think you make a little headway and then you can work in the department, and the language you'll hear, it just takes you back. It's depersonalizing, it's demoralizing. It's, you can understand why patients are so reticent to come to the department. So we need to treat all patients with all substance use disorders, just like we treat all our other patients with any, chronic medical condition. So it's an ongoing battle. There are people fighting for this, championing this cause. I work with a great team at Ohio State of other, not just physicians, but also we have great program manager, Allie Miller, who keeps us on our toes and keeps all our programs organized and keeps pushing us forward. So, and I've been working with the other health systems, Ohio Health, specifically Grant, and then Mount Carmel too. I work with their ED leaders to get them doing a lot of the same work we're doing at OSU. And I'm also championing this cause throughout the state. So I work with multiple counties throughout the state of Ohio through the National Institute of Health to get them at least hoping to do Narcan distribution, but then we really hope that they'll start appropriately addressing patients with opioid use disorder in terms of like stigma reduction, and then putting them on evidence-based treatment, which is buprenorphine, which is probably the easiest access medication for patients in the emergency department. Methadone works very well, but the problem is with methadone, the follow-up care is very difficult to coordinate. So I think that can become problematic. And then naltrexone or Vivitrol, the third medication that is evidence-based for opioid use disorder, in the emergency department, you have to have a period of about like 7 to 10 days where you don't use anything. And for a lot of patients with opioid use disorder, that's not the patient we're seeing in the emergency department, let's say. So with that, I'm looking at my time here. I didn't really have an agenda or anything. I don't know what everybody's backgrounds are, but if you have questions, please raise your hand. I don't know, put something in the chat if you want to do it anonymously. I don't really care. Here, I got a question. All right, let's see what it is here. I'm used to being questions. I work with med students, undergrads, all kinds of stuff. So, okay, here we go. Okay. How much time, if any, are med students required to spend in rotation? Good, okay. So how much, I'm gonna read it out loud. How much time, if any, are med students required to spend in rotation on addiction? Do you feel it's enough given the gravity of the epidemic? So that's a great question. So right now, well, I'll tell you what we've been doing. So that's a big push at Ohio State. What we had been doing, and a lot of it started with the same time that we were doing this grant work. Dr. Julie Teeter, who is the medical director of Talbot Hall, which is our inpatient withdrawal management facility for all substances at Ohio State. She works in the psychiatry department, and she was training all third-year medical students when they were going through their psych rotation. They basically all took the X waiver course. Okay, so she is one of the instructors for the X waiver course to get your training in buprenorphine. So basically, in the last several years, every single medical student who's a third year rotated through, they've all basically taken the course. So when they essentially graduate and become a resident physician and get their personal DEA, which that can take a few years, unfortunately, because you get like a temporary DEA when you become an intern. Will automatically be able to prescribe Suboxone. Now, the addiction rotation, from what I understand, was an elective previously, but I think we're working towards standardizing that curriculum, and I'm not sure if that's going to be in like the third year or fourth year. And I think there's also discussion of bringing it down at the more fundamental level in the first and second year. And so I don't think that's in place yet, but that's something we're working on. But we're also trying to target more immediately the current medical residents. So we're actually targeting that with like a stigma type of campaign. So we've actually been going to different departments, so like emergency medicine, internal medicine, the surgical disciplines. So one of the addiction medicine fellows who's now graduated, along with Dr. Julie Teeter, and we have a couple of like nursing champions. They've been doing these presentations to the different departments, like to target the medical residents as well as the providers. So it is in process for the lower levels, but it's never enough, right? But we need to start earlier and earlier, because I received probably like zero training in addiction medicine when I was a medical student and a resident, unfortunately.
I actually have a question.
Sure.
So
yeah.
When we think of, emergency services that respond to an overdose, a lot of time in America, we think of police. So what are your kind of relationships with the police, and how do you kind of deal with that, especially among those who are skeptical of police presence and that sort of thing?
So by skeptical of what exactly? I'm sorry.
Well, like they were like worried about being arrested for a substance they were using.
Got it. Okay. Yeah. Honestly, I'm from Columbus originally. I did my residency training elsewhere. I went to New Orleans and then I came back. But certainly that fear is always there. But at least, in relation to like overdose, that is rarely on the table anymore. Columbus police carry Narcan. They've been carrying Narcan for several years. The Columbus Fire and most of the EMS townships, we have a lot of like townships in Columbus. Obviously, they carry Narcan too. In terms of who is the first responder, it kind of depends on what the call is. But commonly, like folks, if it's, well, there's never a basic overdose, but there's, we don't hear about people commonly getting arrested after an overdose. I mean, certainly if there is any medical concern, they're not responding, EMS would respond. The EMS, the paramedics and EMTs would come to the scene. And then potentially if they needed more naloxone or still weren't responding, then they need to be transported, to us in the emergency department for further management. But, unless there were other, like, if it's like a homicide or trauma or assault, or then and clearly the police might be involved. Even then, though, if they're acutely agitated, say there's like stimulants on board, like methamphetamine or cocaine, they wouldn't necessarily take that person to prison. They would probably still bring them to us. We tend to, unfortunately, the emergency department, where it's a fine line between, substance-induced psychosis, decompensated mental health. There's a fine line there, and a lot of these patients can be like really violent too. But we're considered the place to like stabilize them. So that can involve, medication, unfortunately, until whatever substance can like metabolize, and then we can actually have an appropriate conversation with them. But we wouldn't necessarily call the police unless there was something else that we didn't know about. But yeah, like a simple overdose with Good Samaritan law and, witness bystander Narcan, there should be no fear of, being arrested. So, but again, remember what I'm seeing is what comes to the department. So, and I think they're trying really to push a lot of legislation to, the simple, Ohio is pretty conservative, right? So possession charges for like marijuana and, other substances, we're trying to kind of really get away from, jail time for those. One thing I do wish, speaking of police and criminal justice, I do wish we had a better intersection between the hospital systems, particularly the emergency, even the inpatient setting when the folks get admitted, and the criminal justice system and the drug courts, because we'll see people, fresh out of jail. I think the jails are doing a lot better job, at least giving naloxone, but like fresh out of jail, not on meds, like overdose within 24 hours, come in, you want to get them to treatment. They don't want to go because they're afraid about like, their parole officer is going to get back to them. And, it's like this person is so high risk. So I think they've come a long way, but I wish we did a little bit better communication across the different systems. So there's chat here. Look up behind you, anyone who knows. Okay, sorry. With a greater variety of substances now being laced with fentanyl, have you been seeing an increase? Okay, college age patients. So I work primarily, and I didn't say that in the beginning, I apologize, but I work, so Ohio State has 2 campuses. We have the main academic campus, near the football stadium. And then we have the campus on the community hospital on the Near East side. So I work primarily in the Near East side. I work over in the main campus, but like on the inpatient side. So in terms of college aged, yes, college students, not as much, but I think that's more the proximity I am to campus. It's, unfortunately, the area I'm in, there's always been opioids. I mean, for years and years and years, there's always been opioids. I mean, I think we did pill mills, up and down East Broad Street. Cocaine has always been there. Cocaine is ever present on the Near East Side. But unfortunately, with fentanyl, it's become way worse. You've got a lot of people who use cocaine on the regular, and it's mixed with fentanyl. A lot of folks don't realize it. I mean, there are people looking for it too, but these are folks with zero tolerance who, you know, are using their recreational cocaine at, you know, party, celebration, whatever. They're 60, 65, because we see a lot of older folks who are using recreational cocaine, and that can lead to a fatal overdose because they have no tolerance. And, you know, fentanyl's like 100 times as potent, you know, as like heroin. So, and if you're opioid naive, that can potentially be a death sentence. So in terms of like it's interesting you asked about the college age distribution. So I'm working with the College of Public Safety. We're actually trying to get naloxone kits put with the AEDs on campus. And just because we think naloxone should have like public access. So we had to look at the numbers of like overdoses on campus. And there actually were very little overdoses that were reported. Now there are overdoses in proximity, like along the bus lines, like along North High Street, but not necessarily on campus property per se. So even though I think the numbers are low, I still think college students are super high risk for any type of substance use disorder, particularly alcohol. And, you know, potentially, like Liz mentioned before, if you've got the right combination of addiction, family history, you know, maybe whatever trauma or some kind of event in your childhood, provided a substance, you know, alcohol, say in combination with trying pills, you think it's oxy, buy it on the street, it's probably pressed fentanyl. That can be a fatal combination. But where I am, we don't see as many like the campus, you know, population. Okay, another question here. How would you suggest we help our folks who have been treated poorly by some, who was charged with providing care to them? Most of the individuals we see have rarely wanted to do anything more than just leave. But yeah, after a bad experience. What could we tell them to do to advocate for themselves if their visit is going in a bad direction? Yeah, that's a super hard one. And we hear that all the time. Patients, particularly the, you know, going back to opioid use disorder, particularly the patients who have had, you know, poor experience, were belittled, were demoralized, were told this was their fault. You know, we moralize substance use disorder, particularly opioids. It seems like in the United States, this is your choice. You do this to yourself. You can get yourself out of it. You know, you should just stop. Why can't you stop? You know, and we would never, ever, ever talk to anyone with heart failure or diabetes, even if they're not taking their medications. They come into the hospital all the time with high blood sugar, have to be admitted to the hospital. We would never, ever disrespect somebody like that. So if somebody, if somebody has a bad experience like that, and they typically have like a medical complication of opioid use disorder, they typically have, you know, pretty advanced disease. And so it's hoping that, well, one of two things. If you ever interact with the Ohio State system, we have something called customer experience or patient experience. And I would advocate using that, because this is an actual situation where it truly is like a customer service. The customer is being mistreated. And that is absolutely true. What we do at OSU East is, I'd like to say every nurse in my department does not have stigma, but that's not true. I think some nurses and PCAs and providers work better with patients than others. And so if there has been an interaction, we are lucky enough that we have advocates in the department, like the peer coaches. So I employ them, you know, potentially changing nursing, changing providers, encouraging them to advocate for themselves. Because the last thing we want a patient to do, particularly with a medical complication, is to leave against medical advice. And it's hard all the time. It's, you know, they may have a bloodborne infection, they need prolonged IV antibiotics, but if something happens or somebody treats them poorly, it's a, you know, it's the roll of the eye, it's the passing judgment, you know, facial expression, comment. That's all it takes for somebody with, you know, already their coping skills are very poor because of the disease process and what it does to your brain. And because they've been so disrespected, so demoralized, their, self-respect is so low that it would just take that one comment for them to leave against medical advice. And I'd like to say that I'm there at all times and can intercede. I'm not. I try to do the best I can, but it's a lot of education to providers across the board. Like we treat patients with compassion and respect. You treat them as you want to be treated. You want to treat them as this as your daughter or your son. And I have many providers, not providers, but like advocates, clerks who've had family members with opioid use disorder, family members who've died from opioid use disorder. So you try to use it as like a moment of education. It's challenging, but we try. And we try to like emulate our behavior amongst our other providers too. Because, in the emergency department, we see people at their worst. I mean, these are people who are acutely intoxicated by that polysubstances. I mean, they're in their worst state. And so you treat them compassionately like you would treat, anybody else. And it can be hard when you deal with this day after day. So I don't know if that answers that, but we try to like redirect best we can. Okay, that's COVID. And tell me where we are with time and stuff. I don't want to. With the onset of COVID, how has the hypothetical window and mobilization for intervention been affected, and how has Ohio State attempted to mitigate potential downfalls? Okay, good question. So interestingly enough, so back about a year ago in April was when nobody was going to the hospital. I mean, like not zero, but the emergency department was barren, and that wasn't just us, it was nationwide. So everyone was staying at home. It was frightening because in April last year, we were having overdose death surges like every weekend. It was like 7 to 11 like deaths every weekend, but yet nobody was coming into the department. So we started working with Matt Parrish from Columbus Fire to start doing pop-up Narcan distributions, because we're like, the people aren't coming to us. Like, where are the people? Like, I talked to leaders at, Mary Haven, at Mask. I'm like, they had beds. Beds were open everywhere. Talbot had beds. Everybody had beds. I mean, it's like an amazing time to get into treatment, but everyone was so fearful, and really hunkering down that nobody was coming in. So unfortunately, as we know, people in recovery were relapsing. They're isolated. They're alone. They don't have their in-person counseling, their sessions. You're worried about patients like not getting their refills for their Suboxone. So I think, like away from the emergency department, from the treatment sector, like Talbot did a pretty good job about going to the telehealth platform, particularly for folks who had to travel to come to the clinic. And so I think in that sense, it did reduce some barriers to access for established patients. So if you were already in care, you could continue your care on a telehealth platform. I mean, they were doing, like mail prescriptions and all this different stuff. So in that sense, it really helped reduce barriers. However, people were afraid to come to the hospital. Like our visits were so low in April, and the hospitals nationwide, lost a ton of money just because revenue was down and surgeries were canceled. But I think a ton of people relapsed too. Our numbers were, in terms of overdose deaths for early 2020, were already bad. And then we hit COVID, and it was just like, it was a death knell. I mean, literally a death knell. And you talk about deaths of despair, due to suicide and like substance use, they just essentially doubled and tripled. So since that time, we really actually saw people starting to come back to the department in May and June. A lot of it was getting the act together for COVID, and like, what do you do with COVID? And so a lot of folks who we see are homeless, and if they have COVID, where do they go? And where do they go if they have substance use disorder? So I think the city did a decent job in dealing with that. We worked with Mary Haven. There was like the shelter hotline where they would take patients who had COVID, who had to isolate, but also needed their medications, whether it be for alcohol or opioid use disorder. So I do think the city kind of rallied on that element. And really by June, our numbers have definitely in the emergency department have been lower not lower compared to last year for April, but in general, our numbers have been lower. But I think lately numbers have been picking back up, and now we're back to old times. So I worked yesterday in the Mary Haven Addiction Stabilization Crisis Unit, was at capacity, and that's old times. I mean, it was always at capacity. So it's like a 55-bed unit, and it's at capacity for treatment. So I think we're going back the other direction, you know, unfortunately, like the patients never went away, right? And I think they're coming back to us, but the problem is they're sicker and not as many want to get, at least what I'm seeing in the emergency department is not as many want to get into treatment, which, you know, can make it challenging. Okay, I also don't believe there's enough care being given to those who give care. I don't think any EMT, crew nurse, or doctor ever thought this epidemic would consume so much of what they do. Yeah, and what care is being offered to all of you so burnout sick. So yeah, in terms of COVID, for sure. This has been a rough, I mean, in terms of being a provider, you know, in a hospital setting, emergency department setting, it's been a bad year. It's been a bad year for a lot of folks. I had a fellow provider whose husband committed suicide, you know, early on the pandemic. And I don't know if this was related to the pandemic, you know, or not, but this has been a tough time. There are a lot of folks who've retired because of the stress, or they're changing their discipline because of the stress. Ohio State, I think, has done a pretty good job at offering sort of wellness care. They have provided us a lot of opportunities to seek counseling. And I know there's been other providers who have sought counseling due to burnout. It's hard to go through the stress of this and then continue and showing up every day. And even in the beginning, there was a lot of, you know, all the media and all the testing and what are we supposed to do? It kept changing. So I feel pretty fortunate that Ohio has been protective of that. And also clinically, I wasn't working as much too, because I do a lot of my time with this grant work and other hospital systems. So I wasn't working as many clinical shifts in the past year. And in a way, I'm very thankful because I think it protected me a bit too. So, but it's real. I mean, burnout is real, particularly among the nursing staff and particularly among folks who are caring for exclusive COVID patients. Like a year ago in May, I worked on a prison unit at Ohio State, and I was just caring for COVID patients. And so that was pretty stressful. Compassion fatigue. That's right. So, okay. Sorry, I realized I probably should turn on the light here too. It's getting really dark. Any other questions? No, the light on. Sorry, I look really dark here.
We're coming up on our time, so we can end it there. I think that was a good ending question. Thank you so much, Dr. Kauffman and Elizabeth, for your time. We really appreciate it. I know that a lot of people who are here do plan to go into medicine. So the stuff that you all talked about was really important. And I know that, at least from my experience talking with pre-meds, sort of substance use disorders and either treating them or interacting with people who may have one or come after an overdose is not really something that people talk about or are interested in, which is a little problematic to see. So it's good, I think, to have this sort of thing. And it's good to hear that there's stuff that's changing in terms of the training of medical professionals. So yeah, so thank you all. Thank you both so much for your time. Thank you everybody for coming. We hope to see you at our future events on Thursday or to stop by where we're tabling on the Oval. I hope you all have a great evening.
Great. Thank you. Take care.